What has struck you about this disease or about kids who present with these kinds of symptoms that you would add for someone listening to this who could be a family or could be a pediatrician or a child neurologist or other physician involved in neurodevelopmental disabilities? Irina, go ahead.
Yeah, with my experience, especially with this 17-year-old boy who was diagnosed at age 17 with AADC deficiency, he was having all this horrible oculogyric crisis and dystonic spasms, and he was untreated for that. And so I think the uncertainty of what's going on with children is so painful for the families. So I think that it is so important to diagnose them. But I agree that some of the, even if diagnosed, more severe cases, not so amenable to treatment. So I had some success with dopamine agonists with milder cases, but with more severe, we just see side effects with dyskinesias and so on. And so it is really, really difficult to treat. And so the whole hope is in gene therapy, about which we're going to hear more. So that's the one thing. Again, when the diagnosis is made, these families, they start belonging to certain groups and communities, and they find more and more from other families about it. And I think that that's very important. The other thing is, like, we think of this condition as being non-progressive from biochemical standpoint, but yet over the years, this patient developed so many complications. My 17-year-old patient actually passed away, and we still don't know why exactly. We suspect from cardiac arrest. And then another patient who is 25 years old, she developed such severe scoliosis that she required to get tracheostomy because of restrictive lung disease. So again, over the years, more and more problems may happen to these patients if they go untreated. So I just let other people do.
Thank you for sharing that. Some of that's heartfelt testimony there. Thank you for sharing that. Jennifer, what can you tell us? And I'm also thinking about something that Irina raised, which is long-term complications in movement disorder patients. So go ahead.
Absolutely. I think one of the things that has been most impressive to me about AADC deficiency is the variability in presentation. I think we often think about the most severe cases, but as was discussed already today, there can be a high variety of severity depending on the type of mutation a patient has. And so I think for me, that variability translates into having a very low threshold to test children, even if they don't necessarily have the most severe clinical presentation, because as has been mentioned, the high impact of successfully diagnosing this disorder, I think is very evident, especially as these new emerging treatments are becoming more and more available. So I think from a movement disorders standpoint, the first step is recognizing these kids and getting them diagnosed, and then really starting to think about what can we do beyond just symptomatic treatment with medications, and then how do we integrate medications with gene therapy to really optimize and maximize function for these children. And I'm curious to see, as the field moves forward, if sort of our threshold for who to treat changes, because as Irina was just suggesting, these children have really profound implications for development. And I'm very movement centric as a movement disorder specialist, but even if their movement disorder isn't the worst part of their presentation, they may really benefit from better control of the dysautonomia, or have really potentially profound effects on improving their development with treatment. So I wonder kind of what the future holds, and how we will address who to treat and who not to treat as we think about those issues.
A lot to work out there. Warren, you said that you're closely aligned with physiatrists, which makes a lot of sense. And I'm wondering if you have any comments on who treats these kids, who sees these kids, do you have a system? You're in Texas with a rapidly growing population, is my understanding. Do you have a system there of centers of excellence? You know, how are kids triaged and seen, at least in your area, if not more broadly? Do you have any, can you make any comments on that?
So that, I mean, it's a really complex issue. Our group of neurologists actually made the decision to incorporate physiatry into our group. So rather than competing against them for procedures and the way we're managing patients, we think it made much more sense to get in, sit on the same page, and kind of divvy up the management so that we both learn from each other. The physiatrists are learning more of the neurodiagnostic skills from us, and they're helping us with our management skills. We all do a lot of the procedures. We all do medications. All the people in our movement group do, you know, chemodenervation and things like that. And some of us have done our own bracing over the years, but it's nice to have people that are really focused on that. And so I think, you know, our skills are probably more in the focus more on the medical and surgical management. But we do try and take a holistic approach to how we treat neurologic disease, not just this. Actually, one of my epilepsy colleagues and I, many years ago, actually wrote an article on the habilitative approach to epilepsy management, of thinking more than just seizures, thinking in terms of the whole child and the whole family. And yes, seizure control is important, but there's more to it than just seizure control. And that's probably even more true in movement disorders. Sure, controlling the movement disorder is very helpful in CP, but it doesn't solve all of their problems, and it doesn't help all the family's problems with the progressive skeletal abnormalities that you can see, the respiratory involvement, the feeding problems, and then all the social and economic implications of all of that, which are huge for families. It's very hard to work when you've got to be home taking care of a child who's dependent on you for everything. And so this has lots and lots of implications. I don't know that we in the United States even have done a great job of really developing true centers of excellence that everybody's comfortable referring to, but that clearly is the way to go for rare diseases. You don't need 25 places trying to do gene infusion therapy for the 6 children a year that we're going to see. Nobody's going to get good at that by doing that, and we're not going to do a very good job. And so we need to recognize that there is a real need for places that can do these highly specialized treatments, and that not everybody needs to do everything.
Really good points. Really good points. It reflects a lot of experience in the real world.